Um, I've been ready for this session for like the last probably year or something. Um, and have been sort of just kind of building up in my head a lot of um, thinking about how we approach talking about pulmonary embolism. And I think as was noted as Andy was walking through our performance over the years, we're doing quite well, but I've had a slip, and I think it's time to kind of think about and rededicate sort of how we approach this. And I'll talk through some vision here, and then Alex Sankey, who I don't know if you exactly know completely, but he'll introduce himself. We'll talk through some of our data a bit on this problem of potentially misdiagnosis that people fear. And then Chris is going to round things up with a give and take about SIM or Tableau dashboard reporting. And then we'll wrap things up at the end of that. Like we said in the beginning, I don't think we're sharing any sensitive data here. I think this is all like group aggregated level information, but please don't take screenshots along the way, certainly if that's the case. The way I'm going to structure my talk is, I really want to talk about where we've been and where we are. And then I really want to focus on like where I think our opportunities are to improve. And wrap things up with at least some review of the newer evidence that has come out in the last couple of years. And then we'll bookend that with some conversation with Carrie about how abstractors approach their data abstraction, and just to look behind the curtain about that process, you understand some of the challenges and also some of the tips around how we do that and could do that better. I think the bottom line here, just to understand a little bit of the why, is we do a lot of chest CT scans for pulmonary embolism indication in the emergency department, generally speaking, certainly across medic. Here's some numbers, and the timelines here are basically the last 2 years of registry data, and we'll kind of use that last 2 years throughout here just as a way to keep the timelines similar. And if you were to look at simply the rate with which, if you walk into any of our emergency departments, the likelihood is that you're going to get a chest CT for PE. If you're an adult, on average, it's like over 3% of the time just walking into any of our ERs. But there's considerable range around that, and I'll show some data around that, variation. And this totally outstrips the amount of scanning that we're doing for minor head injuries in adults by about 5 times. You can see we did over 50,000 of these scans last year. And this is in relation to a lot of good evidence around how we should be approaching these decisions that we'll talk about. And I think my other point is that diagnostic yield may not seem like sort of meaningful numbers, but small changes in diagnostic yield in relation to the large number of scans being done here make big differences in the potential to avoid some of the scanning. So even a change of 2% diagnostic yield may allow us to avoid upwards of 9,000 CTs. So just kind of keep that in mind as part of the why around why we're doing this work. So let me just walk through a timeline here about how we got to where we are. This was one of our first quality initiatives.
The same keyway. This is to the front door at your house.
At the lake
started
house,
with. Sorry, let me just mute that. And it was part of our performance measure starting in 2018. And then in 2019, we actually pulled together a working group across our network, led by Seth Krupp, where we recognized we needed some standardization, some sort of guidelines around how we think about improvement here, and walk through the evidence and came up with guidelines and toolkit. That was in 2019. And then COVID started. And we recognized some of the challenges in the overlap between patients with COVID and decision making around chest CTs, and basically paused this. Put it on the back burner. Didn't emphasize it as a quality initiative. Wasn't in any of our pay for performance measures, and that's where it's been for the last couple of years. And you'll see, we've had some decreases in performance. Not always because of our decrease in focus. I think there's a whole lot of other factors there. But I think our recognition is like, what can we do to reinvigorate this? And certainly in the 2024 pay for performance measure, it's now there. It's actually a group measure. Here's a little bit more of a deeper look into what the performance has looked like across the collaborative. And you can see we did quite well, into 2020. And then, as I said, really the last couple of years, we've had a decline in our performance. And if you look at it sort of on a month-by-month basis, it's been consistently sort of under where we'd ideally like to be. We've built out quite a lot of implementation support around how to go about improving here. On the top left side is a YouTube video of a talk from Jeff Klein. This goes back a couple of years when he was a expert speaker for one of our meetings, talking about the evidence around PE. We've got a slide deck that also walks through the evidence available off our website that can be helpful, getting the attention of healthcare providers. We have the clinical guidelines as well in various forms as part of our materials as well. I think it's important too, when we think about measurement, to always go back and understand like how we go about doing the inclusion and exclusion criteria. If you ever wonder why your performance is the way it is, I think there's oftentimes some assumptions about sort of how we go about doing that work and measurement. And so it can always be useful to go back to our approach. And so this is available off our website too. The bottom line is really looking for two different CPT codes that refer to chest CTs with IV contrast, and that's really the denominator here. And then it's simply, how often those are positive, and that's how you calculate a diagnostic yield. I'm going to be referring to this clinical guideline along the way here. But this is what I was referring to that emerged from the work group that we did in 2019 as we walked through the evidence. Of course, there's lots of ways to think about the approach to diagnostic testing. We chose to use a combination of Perk and Wells in combination also with age adjustment of the D-dimer. And again, I'll sort of reference this a bit along the way. Okay, so let me talk about where I think our approach could be and how we've built out help in your own process in our reporting capabilities to make some change. I'm going to pitch this as a QI social contract. I made that up, but you kind of get my point. We've really invested a lot on the coordinating center side to understand, where we think we can help and how we might go about doing that. I mentioned, setting this incentive for 2024. That target is 8.5% diagnostic yield. We're going to advocate for change. Obviously, that's what we're doing in this meeting right now. We've improved our data collection and capture. We actually went through a process in the fall where we asked all our sites to give us their D-dimer information, so we know what assay is being used. We know how to calculate a age adjustment based on that assay. We actually have also hoping to include in our future monthly feedback data transfers from all our sites, whether or not a D-dimer test was done at all, not just on the population that gets a CT scan. So now we'll have a better understanding of how often that test is being leveraged. And we've got a bunch of new reporting capabilities that we're going to walk through in a show and tell from Chris Fung at the end. So that's our side. I mean, what I hope from your side would be, dig into these data and reporting. Think about where your opportunity is. Where is the highest impact, lowest effort approaches? I'll give examples of where I think that could be. And really just set a quality improvement agenda like anything else. What are you going to do tomorrow? What are you going to do next week to begin to make some progress forward? We hear a lot of basically complaints, feedback about this measure, and I just want to walk through how I think about it, how we think about it. I think they fall into kind of two categories, which I totally agree with. One is, there's no information with diagnostic yield about the adherence to a diagnostic process. Unlike, say, with the adult head injury measure, where we are basically measuring against adherence to the Canadian CT rule, we don't do that with diagnostic yield. So you're not necessarily sure about how well people are adhering to the evidence. One thing I just want to point out about this, because it comes up a lot, and we've talked about it at various points, is it's actually not feasible with any kind of measurement or data collection approach to do that adherence process with pulmonary embolism. It's a much more complex decision-making process. If you're thinking about PERC, for example, you wouldn't know when PERC is applied. There's no way to understand that. Wells has a lot of kind of criteria that isn't capturable in data. For example, this thing that's mostly in people's head around the kind of likelihood that PE is the main diagnosis of concern here, you're not going to be able to capture that. So we don't have a way to feasibly measure adherence. I think the other really important complaint or feedback is that it's not also actionable. Because we're measuring outcome, you don't really know the process. And if you don't know the process, a lot of times you don't know how to begin to make some change because there's no feedback around that. And this is the one I think we've really tried to listen to and respond with what we're going to talk about and share throughout today. I will say the advantage of measuring an outcome like diagnostic yield is it's flexible. It doesn't matter what process you adopt. You could use PERC and Wells, which is, what we've endorsed. You could use anything else that's come up as evidence-based, the years criteria, for example. It's all perfectly aligned with optimizing diagnostic yield. But at the end of the day, what we want to focus on is like, how do we help y'all and individuals improve? And we've taken that to heart. Over the summer, we dug into our registry and really tried to analyze, where the population is being tested, where are those opportunities, and then how do we begin to synthesize that into some tactics to improve. I mentioned the sort of improvement in our data capture around D-dimer, and then really developed better audit and feedback reporting capabilities, which we're going to walk through. Okay, so that's setting the stage for what we've done. Now I want to talk about where I think our strategy should be to improve. And here's the conceptual framework. I'm adopting it from something that's been applied to antibiotic stewardship. And I really like this paper. came out a couple years ago, and it talks about these like key high leverage decision moments. This is for them with respect to antibiotic stewardship, but I think we can apply this same concept to effectively what is diagnostic testing stewardship. So those like 3 moments, I think, of PE testing decision making. What are those, and how do we understand that, and how do we begin to sort of report around that in a way that's actionable? So I'm gonna walk through these. So moment number 1, and we call this out in our clinical tool, is really this decision: are you going to embark on testing or not? And I think we all kind of intuitively recognize this. We call it out as a pause pre-PE moment, and even have this, what I think is a really great quote from Jeff Klein and Chris Cabral from a publication they did a number of years ago, about the challenge around this decision. It's because pulmonary embolism presents with non-specific symptoms, chest pain and shortness of breath, others, that you can basically encounter routinely all around you in everyday practice. Many of these individuals don't have PE, but some might. And so deciding when to initiate that testing pathway really can be hard to determine. And that's why I think this kind of pause moment could be useful. I think the challenge is we can't probably report in a way that is as actionable as I would hope. But I do want to present some data that we have. This is at this kind of aggregate site level. What you see on the x-axis is that rate of PE chest CT testing. I mentioned this earlier. We've got a lot of variation, somewhere around 2% to somewhere over 5% by site. And then on the y-axis, you see diagnostic yield. And there is this negative correlation where, the higher likelihood of a site to engage in CT testing, the less likely their diagnostic yield is, or they're more likely to have lower diagnostic yield. And to me, this really suggests there are different, test thresholds across our sites. I think we're going to learn a lot more when we now have the D-dimer testing I mentioned earlier for those that are just perhaps only getting that and not a CT scan. This is, I think, more in the category of thought-provoking and being mindful of, and again, less actionable. But the basic nudge here is, that pause moment. Think about, is this a patient you really need to test on? Okay. I think the second key moment is really going to be the most impactful one. And it's a D-dimer first. The moment is, have I ordered the appropriate first step in the diagnostic pathway? Do I need to jump straight to a CT scan, or can I start it with a D-dimer? And I gotta say, like, this is my personal problem, as I kind of reflect on my own practice. My diagnostic yield has slipped, and I think this is where I can do better myself, is to think about D-dimer first. So let me walk through kind of how we thought about this when it comes to measurement and reporting. So we can't, of course, measure all the factors that determine whether or not any particular patient is in the low risk concern for PE or the higher risk concern. You can see if you pull out the PERC criteria, many of these factors are not going to be in structured data in a way that we can get at, hemoptysis, recent surgery, unilateral leg swelling. But what we've highlighted here is there are some objective data here that we do have consistently in our registry for all these patients, and that's age, heart rate, and hypoxia pulse oximetry. So if we were to segment our patient groups into what we call a lower risk one, so where there's one or fewer of these risk factors, and an elevated risk, kind of two or more, we think this is going to provide some pretty good insight into how to improve. And I'll show you what I mean by that. So when you begin to do this, and segment our population across the registry into these two groups, what you find is we actually scan the majority of our CTs in this low risk group. Almost 60% of our patients are in this lower risk group. And then when you dig a little bit further and ask how often do we start with a D-dimer in this low risk group, we find it's only about half the time. And I think this is really our opportunity, is to think about leveraging that D-dimer first. I put in, sir, I know somebody's going to be curious about how often those 20,000s ended up in a CT positive scan. I put those numbers in. But the bottom line is like almost 30% of our CT chest population is lower risk, I should say, and we did not start with a D-dimer. And again, I think this is really our opportunity. If you look across the collaborative, we have highly variable rates of D-dimer use in that low risk group, all the way from like a quarter of the time to close to like 100% of the time. Again, I think showing like we have opportunity here, where we can improve that D-dimer first decision, particularly focused on that lower risk population as a strategy here. So I think the nudge is D-dimer first, particularly in that low risk group. All right, so I'm going to walk through, I think, what would be the third moment. And this is something we've talked about from the beginning, which is age adjustment. So once you do all the testing, get the D-dimer result back, the moment is, how do I interpret that lab result? And I'm not going to unhash like all the evidence around supporting age adjustment. We've walked through this probably in the past a few different times. I pulled out a slide from our slide deck that just acknowledges some of the literature around this, a JAMA study, a BMJ systematic review meta-analysis study, that really supports age adjustment as being safe and effective. I got to say, this is really eye-opening to me. When we went through the process of getting the D-dimer assays, so the lab reporting across all our sites, like, oh my gosh, like no wonder it's hard to interpret some of the results. I think this really is a barrier to action. I'm showing the same assay from different hospitals in how they report out, their D-dimer results, and it's hard to even know what the right actual positive rate is, threshold is on some of these. And obviously, the challenge is D-dimer is sometimes used for other purposes, for DIC, for example, and what is the value for DIC versus VTE? It can be different. And sometimes you get some help around how to interpret age adjustment, and sometimes you don't. So I get why it's a barrier, like even more clearly to me now. The bottom line is there's really only 3 assays across the collaborative that exist. And it just has to do with what their units of measurement are and the properties of the assay. Number 1 is the one I'm used to, where it's at a 0.5 threshold level. The other one is the one I'm more aware of too, which is at using sort of 500 as the test threshold. And then I think a lot of the Trinity sites use this other one, where it's like a 250 threshold. But the age adjustment is not that hard at the end of the day. It's a bit of some decimal changes. And the one that Trinity uses a lot is just H times 5. So the actual calculation is not that tough. I think it's a matter of sort of understanding, how the approach should be done. So we've built into our reporting the capabilities so that now that we know what your assay is and your test thresholds are, you can actually know how many potentially avoidable scans could be available to you and certainly across the collaborative if we all applied the age adjustment standardly. And you can see in the last 2 years, the collaborative would have saved around 2,300 scans, about 1,000 more recently. So I don't think this is like the biggest impact, but I do think there is some opportunity here as well. And so the nudge would be, again, just think about you should be doing age adjusted. All right, so let's take the next step here. And we think about the moments that I'm describing here and the strategies. And I personally always like this impact versus effort matrix as a way to think about how to take a next step. And I just populated this as I would apply it to maybe the collaborative. But the point is, like, you would want to tailor this to where you think your local opportunities are, and it may not fit this description right here. But I think the age adjustment is more on the lower impact, as I said, but perhaps, lower effort, because you're not necessarily having to change the behavior around the testing itself, but simply how do you interpret the test result. And if you have the right sort of understanding across your group about how you interpret that test result, maybe there's some opportunity to improve here if that seems to be the case for your site when you look at your own data. I think number 2 is the highest impact opportunity. I called this out already. It's that D-dimer first. You're going to be able to look at your own site's behaviors around how often you're using D-dimer for that lower risk group, and see if that aligns with where perhaps your opportunity exists too. And then finally, I think the trickiest one is this pause pre-PE, because we can't provide a lot of measurement around that. But I do think we're going to have some future reporting capabilities here, because we are going to get that D-dimer information regardless of CT. So we'll have a better understanding about all the test thresholds across our network as well. And I think in the future can build that into our reporting. All right. I'm going to wrap things up and just highlight some of the newer evidence, because this comes up and I think it's worth calling out. This is not a deep dive. This is not like at the level of evidence review, but I think just for people to be aware. So first is years criteria. This paper came out in 2019. I think there's been several other papers. There's one on using years in pregnancy, for example. But really what I want to call out here is, like, this is a full on like D-dimer first approach. And really consistent with, what I've been describing as our kind of opportunities to improve. There is no jumping straight to CT with the application of years. For those that don't know, you start with a D-dimer, and then you adjust the threshold for interpretation of that dimer actually by applying the Wells criteria afterwards. And so if you have Wells positive criteria, then you interpret at a lower threshold, and if it's Wells negative, you interpret the dimer at a higher threshold. But the point is, evidence-based and D-dimer first approach. The other thing I just want to mention is a paper that suggests yours is compatible with PERC. So you could potentially use both in conjunction with each other. And I'm not advocating that we should all switch to years. I think our guidelines are great, but I just want to emphasize a couple of these areas. And then a newer paper that came out last year that was looking at yet another approach to diagnostic testing. They call it the adjust unlikely criteria, but also a D-dimer first approach. And then you basically stratify your interpretation of the D-dimer based on whether or not you think that patient is likely or unlikely to have pulmonary embolism. So kind of a version of Wells criteria on some level. And then part of that is actually age adjusting the D-dimer. So kind of 2 points, 2 moments as part of this. So I'm going to wrap up, really just kind of emphasizing, my thoughts here. I really want you all to think about these 3 moments and how to use that as a window into improvement. Please dig into your own reporting. We hope it can reveal, some of these opportunities for all. And then please set an agenda. Think about where your effort impact matrix is and where you can begin, to make some improvements. I'll pause there. I know that was a ton. That was kind of like a download of my thoughts for like the last 6 months. But happy to take some questions or comments in this moment, and certainly along the way, or offline as well too. Oh,
Hi,
I see a
Keith.
hand raised. Yeah, okay.
Oh,
Oh, actually, go ahead, Giuseppe, and then I'll
sorry,
get to you, Jason.
I had sent you a question in the comments here. I was just wondering if these findings are the same, whether it's a teaching shop, non-teaching shop. I'm assuming they're quite similar because we've had age-adjusted dimers for years now, and we're just kind of like stagnant. We're just at this 8 point something percent. We're not going up, we're not going low. I mean, it's going to be more, I think, the higher level things for us that change the pattern of everyone's kind of behaviors and whether they, for the most part, when I work, everyone's ordering dimers, but for some reason our yields are kind of the same. So there's probably something that we're missing that, I feel like we can do a better job in everything you mentioned there, but
Yeah.
those 2 big take home points we're doing consistently. And we're kind of struggling what the next steps are, but I think it's just going to be the same old, and keep reminding and keep, educating and things like that. But I just was curious if you're finding the same data, whether it's a large teaching center with residents, if it's in the community. Is that something that you've broken it down to?
We have not, in my mind, sort of done that kind of stratification by, academic versus community centers. I'd certainly be curious, what we might find. I think it's pretty easy for us to dig into that. I think your other point is around like, how do I make my own sort of site improvements? And this is where I'd just say, like, look at your data. I think sometimes we have assumptions about what we're doing, and then things maybe get revealed. And I'd be curious about sort of that D-dimer first. And I hear what you're saying. You feel like you do that pretty consistently, but maybe not, and I can certainly take a look myself when I dig into the reports again after this meeting.
Yeah, I mean, you put Seth's name up there, and that number was impressive for me. I didn't realize he was that high, but he kind of just, he's like, I don't even, if it's not even in my head, I don't even order the dimer. So I think he's more of the mindset where he's not even pursuing that initial kind of branch point, and it shows. I don't know what his miss rate is, probably not very high. So maybe he's on the right track there. So we'll touch base with that. But that was impressive to see his number of 23%.
Yeah, fair enough. A couple other questions. I see Jason, you got your hand raised.
Yeah, thanks. I was sort of similar question. I was interested in that D-dimer data. In our sites, we've pushed that pretty hard. I think we've pushed a very similar diagnostic algorithm to what you've displayed here. I suspect our D-dimer utilization is pretty high, but I wondered if, and maybe you mentioned this, I'm sorry if you had, but I saw that site level kind of graph that showed the differences in D-dimer ordering. And did you notice that correlated well with diagnostic yield? I mean, was it
Yeah,
kind of a
it's
linear
that's a great
relationship, or how did it
question.
look?
Yeah. There is a correlation. You know, it's stronger than that one I showed, sort of negative correlation between sort of testing by diagnostic yield. It's not perfect. So, for example, the highest performer D-dimer is up, you know, towards 100%. And they have a pretty good performance. It's not the best. And so this is where I think you need some tailoring. You know, I don't know sort of all the details of their operation. They may be testing too much. You know, they may not be not doing enough of the sort of pause before they launch onto D-dimer. I don't know. But again, I think this is where you really need to sort of dig into your own reporting and understand some of the differences in comparison and where those opportunities might sit.
Thanks.
Yeah. Sarah.
Yeah, thanks, Keith. I really like having this discussion. I think it's really important to kind of understand how much can be saved, not only in terms of cost, but in terms of radiation exposure and our boarding crisis forever. Like just throughput time, right? Just getting people in, out, or dispode. I think one of the things that I really appreciate and that we've seen at our site is like really emphasizing the D-dimer seems to be a really key first step. And especially those of us who are in medical education, really emphasizing to the residents. I feel like there's still this ongoing theme that I remember from our own residency days of like, oh, this patient just looks like they're high risk, they have cancer, we're just going to go ahead and CT them. In saying, you know, like actually that doesn't necessarily make them high risk, that actually puts them into a do a D-dimer category. And a lot of times just working with your learners, they'll be surprised that somebody actually has like a very low D-dimer even with that. And I think that, again, I just wanted to say thank you. And then I think that this is really great, especially the emphasis on the D-dimer.
I appreciate that, Sarah. And I totally agree. Like, as I reflect on my own practice, like I think that I sometimes get too influenced in those sort of trainee PA moments where I haven't seen the patient, it's busy, you know, I just kind of like, you know, go with the plan around just jumping to CT. But I think the bottom line is there is some safety and security in starting with the D-dimer. If you think about yours, for example, I mean, it's built entirely on that principle to begin with. And so I think for me, next time in those moments, I'm going to have a bit more confidence and say, like, just start with the D-dimer and I'll get to see the patient too. But as a sort of, for me, own personal kind of plan of attack. And agree with your comments.
Yeah, the only other thing that I would add, Keith, and sorry to jump back in, is that
No, sorry.
emphasizing that if you want to get the CT after the dimer is negative, I mean, you can always order just the CT of the chest if you think it's important for some other reason, like seeing pneumonia that's not picked up by the X-ray. It doesn't have to be a CTA.
Yep. Beth, I see your hand up too.
Yeah, so I had a question on that part where you were talking about the perk and the low and high risk factor. Were you, because it seemed like if you thought it was a low risk factor, we wouldn't even need to move to the D-dimer.
Correct, for sure. Like
right?
if they meet perk criteria, for sure. I think for us, you know, we don't
Right,
have the
no, but
ability.
I was
sorry.
talking about, I think you said if they had one risk on that, they were still considered low risk. Because that isn't the way it currently lives, right? On the
Correct.
algorithm. Okay.
Yeah, so I wouldn't characterize it as quote low risk. Like we are confident they are a low risk group. I would use the term lower risk, and I think you'd see on our slides that we use that term lower risk relative to the other group, which has a higher risk because of those factors. So I think that's a really important point, is to recognize, you know, the way that we are approaching describing these in the definitions in these populations. It's not the same thing as what would be like in clinical practice, because there are going to be some elements there that shift, you know, those patients perhaps.
But were you suggesting that you were, I guess I just wasn't sure clinically if you thought that we should consider thinking about that. In the ones that are, right, because I don't apply perk if I'm not worried, you know, right? So don't, you know, I mean, I pretty much use similarly the algorithm, you know, that Medic has is pretty much how I
Mhm.
work.
Yeah.
But if patients have one perk criteria, then I would say most of my group says, okay, then, you know, I'm in the bucket and I need to do something. Because I already entered down the pathway that I'm thinking about PE.
Yeah, it doesn't sound like you necessarily have to change your approach or how you think your colleagues are approaching this. And the way that we are describing kind of these lower risk versus higher or elevated risk populations is not to say they align with how each patient should be judged, you know, in the clinical practice, but as a way to think about how to go about improving, sort of at more of a population or group level approach.
Thanks.
Sure. Yeah. And, you know, certainly we can follow up more, you know, if there are questions that remain. I'm going to shift, just looking at the time, to Alex's presentation. But I really appreciate you all chatting about this as we kind of think about how do we improve. Oh, sorry. Before we do that, sorry about Carrie, we've got to work through some of the cases here.
Yeah, I can do this pretty quick. Thanks, Keith. So in this one, I just wanted to kind of reiterate how the abstractors look at this and some of the challenges that we face overall with to determine if the chest CT that was performed was done to rule out a PE or not. And this really kind of relates to our pause pre-PE section, basically, is thinking about, you know, when we start writing down, going through our whole history and physical and going through our MDM and what are we doing, this is kind of more applicable to that part. Because some of our patients, of course, are, you know, pretty sick and come in and they have a lot of things going on, and there's could be quite an extensive list of differential diagnosis. So for us, when we look at if it's a CT done for a PE, it has to be just on the list. Doesn't have to be the main one. It just has to be on the list. So we keep that in mind. And the big one too, I think, is that third bullet point is even though a PE may not be high on the differential list, the CT scan is still being done and used to rule it out. So we've got to take that in consideration. And some of the other challenges we have is that, you know, there's protocols and ordering indications for the chest CT, and it varies by facility. So it's not always very clear in the documentation. Sometimes we have some vague documentation, which is understandable, right? Because a lot of times we don't know exactly what is going on with our patients and we need to figure it out. And then, so what happens though, if we don't have pretty clear documentation, then the abstractors use a hierarchy guide from us to determine if a PE was at least going to be considered in the list of differential diagnosis. So I just want to briefly go over that hierarchy that we have. So the first thing we do is we look to see, because our direct question is, was this chest CT performed to rule out a pulmonary embolism? And we can answer yes straight off the bat if you have directly in your order set an EMR that literally includes an order set that includes CT chest for pulmonary embolism. So that's an automatic yes. Or if you write in the indication for the chest CT, PE suspected, again, an automatic easy yes. Or if you directly list in the differential diagnosis in the MDM that a PE is also suspected when it's, you know, written out, then those are all easy yeses and we move on and we can finish the abstract in. But what happens is next, if we don't have any of those three, then we have to make a determination whether, you know, we think that PE could be in the list or not. So what we're going to do is kind of work backwards on that history and physical. We're actually going to review the full MDM. We'll go back and review the HPI. We'll review the physical exam, and then we'll also clearly look if a dimer was done. So when we look in the MDM, we want to know, does the provider note that there's a clear concern for one diagnosis only? Like if they're like, oh, I'm only concerned about a dissection and it's pretty clear, then if that happens, then we're going to say, yep, it's a wrong cohort. We're not looking for a PE. We're pretty confident. But if it's not clear, then that means we have to look at the MDM. We're looking at risk factors, the physical exams, and if a dimer. And then so if it's still not 100% clear there, then we switch up to the HPI and we look, are there positive risk factors, positive physical signs? So we just kind of keep working our way backwards until we can have something that we can say more on a way that, yeah, it's a higher likelihood that a PE was included in that differential diagnosis, or if it wasn't. So the dimer results make a big difference. So on the next two, I do have two quick case studies that we can review, and these are actual cases from live people, and this is the documentation that was received. And so the abstractors had to parse through this and determine, if the CT was going to be done for a PE, if that was in the consideration or not. So of course you can see the important parts. I've bolded most of them. We have some risk factors of the breast cancer, the obesity, the smoker, and shortness of breath. But the MDM, this is literally the full MDM, and it just talks about, the symptoms, what was going on, increased work of breathing. They said a bedside echo was done, the chest x-ray, and the chest CT demonstrated this. So there's no reasoning or thought behind why the CT was done in the first place. So again, now we got to work backwards and figure that out. So if we can, So the first thing too, also the indication for the chest CT order only said dyspnea and tachycardia. Symptoms, it's not a diagnosis. So again, we have to kind of take considerations. So there was some, clear bunch of points that you can flip right through these to the end part of that. No dimer was performed on this one. That might have helped us. So we followed the hierarchy, right? We went through the entire MDM, didn't find anything, went through the HPI, found some things. But in this case, because we had risk factors and physical assessment exam, positive findings, and no dimer, we did go ahead and choose yes for was the chest CT performed to rule out a PE. The next case is similar-ish to this one. It just had a little bit different symptomology on the bottom. Again, this person comes in, they have all these things going on, shortness of breath, diffuse chest discomfort on this one. It was also noted he had stopped his blood pressure medications, recently stopped losartan, but he didn't feel he was fluid overloaded. We do note that in the MDM, we noted all of his symptoms, things that we're thinking, but in this one, we did note we do have a mildly elevated dimer, right? And then he said consideration, for current symptomology may be due to potential overdiuresis and other contributing factors. So what do we consider other contributing factors? Could a PE be in there? Might be. So they did. And then they did mark right away. Chest CT was done, shows no PE. So that kind of leans towards they were probably thinking about it because that was the first thing they mentioned when they reviewed that entire CT. And the indication for this chest CT was only shortness of breath. So again, it didn't leave us with much. So now we have a slightly elevated dimer. We went through the MDM and the HPI. And then again, the abstractor would have marked yes to a positive that we thought it would be for a PE. So kind of what I'm bringing up to the group, because like I said, this is only for those cases that we're not really sure because we don't have it explicitly spelled out, which is always helpful, but clearly not always feasible to do that. So we've come up with a number of potential key phrases that could be noted in the MDM if there is no concern for a PE, and they're all kind of listed there. PE not suspected. I know some people are also happy with that last bullet point under that one. The history and exam are not consistent with the PE at this point. Of course, this is all your thoughts, and your provider's thoughts prior to even, getting the chest CT. It's like, what is your thinking? What are you leading? What pathway are you going down? And also some places have the ability to either put in a dot phrase, almost the epic, but there's also people who do these cut and paste, just little algorithms that they throw in there, and you can put something as simple as PE suspected, yes or no. So we have some ideas here, but honestly, we have some places that are able to do this a little bit easier than others. So we're just looking for help. Is there better ways for us to help the abstractors to be able to parse through these cases, that are kind of nebulous and figure out, was it actually being done for a PE or not? Because that might help us, in even our overall numbers. So if anybody has any thoughts, I'd be happy to, if you want to share, how your group approaches it, happy to listen and happy to help with anything.
Yeah, I see Lee's comment. I think in summary, I think his thought or concern is like, if we have an indication for a study and the radiologist notes no PE, then it would be unfair, I think, to count that as an indication for PE motivating the study. I don't think that's an issue. Like if the CT is clearly indicated for aorta, it's going to be coded as not in this like cohort. I think the problem is when the indication is some symptom-driven indication, tachycardia or shortness of breath, and it's a CT angiogram, then we have to sort of work through, you know, is this being legitimately done for PE or not? And that's, I think, where our trap is. So I don't think your point is an issue, Lee. I think it's more this other challenge. Thanks, Carrie. And you know, I know that's a big topic too, and I don't want to shortchange it, but I also am mindful of the time. So let's move on to Alex. Why don't you take it away?
Yeah, it's very hard to go after Keith and Kara, but I'll try to be brief. So for those of you that don't know me, I'm an emergency medicine physician and health services researcher in a research fellowship at the University of Michigan, and have been working clinically at Hurley Medical Center at the VA, and now most recently at Michigan Medicine since coming here a little over a year ago. In contrast to what we have been talking about so far, I want to wade into a space where the science is not very good. So as compared to the prospective clinical research on how to approach the diagnosis of PE, I think we know very little about PE diagnostic error. And I think it's, you know, potentially Medic has an opportunity to wade into that space in a useful way. And many of you will remember in December of 2022, the Agency for Healthcare Research and Quality released an almost 1,000-page report on diagnostic error in the ED setting. Among the claims was that 350,000 Americans suffer permanent disability or death each year due to diagnostic error. And among the most concerning conditions was venous thromboembolism and PE specifically. We've seen estimates like this come out and into the media space before. I think the best example of it was the Institute of Medicine's To Err is Human report back in 2000. At that time, it was estimated that 98,000 Americans died due to any kind of error in hospital settings across the US. And so at least at a high level, at a 30,000-foot level, it seems we're doing very poorly and much worse as compared to 24 years ago. In the case of pulmonary embolism specifically, the ARC report estimates that the diagnostic error rate is 20%. They cite 3 studies, all single center, all from outside of the United States, to get at this estimate, this 20% estimate, and they call it the false negative rate. So the number that they are trying to talk about, the number that they are trying to quote here, is what is the rate at which amongst the patients that have acute PE in REDs, how many of them are people that I'm going to walk in the room and not identify that they have an acute PE? That's the denominator and the numerator that we're talking about. And if you take a moment and do a deep dive on the 3 citations that were used to justify the 20% error rate, it's truly extraordinary how much these are orthogonal to the problem that we as emergency clinicians, you know, really struggle with, the risk of rare but devastating diagnostic error. So 2 of these 3 studies, it's very interesting, are about not diagnostic error, but rather delay to presentation and diagnosis. So the Jimenez Castro and Chan et al. Papers are both about patients who, when surveyed at the time they're diagnosed, say that their symptoms are greater than 7 days old. And then the third of these studies, which does at least sort of attempt to get at the question of true diagnostic error, that is an opportunity to make the diagnosis that was missed, is limited to a relatively ill hospitalized patient cohort and does not make the distinction between PEs present at the end of hospitalization that might have developed during a hospital stay versus those that were present in the ED from the start of a patient who was hospitalized. And so if a patient was in the hospital for 14 days, developed a PE on day 10, it is assumed that that is a diagnostic error. And so it's interesting to me, we have this like kind of foil where we have extraordinarily strong, well done prospective clinical evidence on the right approach to how to risk stratify patients for acute PE, but we have basically no published literature on the, I think, true anxiety that drives many of us to overuse CTPE, which is the risk that we see a patient and miss it, specifically patients that we discharge from the ED who might have had a delayed diagnosis of PE resulting in morbidity and mortality. MEDIC maintains a balancing measure for the CTPE diagnostic yield. Right now, the way that it is defined is all-cause ED visits within 7 days prior to an ED visit for diagnosis of PE. And this is kind of our approach to quality assurance. It helps us monitor for unintended negative consequences. If we're doing a good job applying the evidence-based standard, we know that that evidence-based standard works, then we shouldn't expect at the margin a trade-off between diagnostic yield and diagnostic error. And I think that our data so far support that. And I want to show you the balancing measure as it is devised right now, estimate, between 6 and 7% of positive PE cases are positive in the balancing measure. And that is not associated over time with the CT diagnostic yield itself. The same is true both across time and across sites. There is not a relationship between our balancing measure and diagnostic yield. And so we've done some scholarship widening out the time frame to 10 days to increase the capture of visits and sample, and dug around in the data, understand the chief complaints, the discharge diagnoses, sort of who are these patients and how do things go for them when they have this potential indicator of a diagnostic opportunity, however imperfect, with the important caveats that revisits may sometimes cross sites and systems in a way that we can't identify, that revisits often represent a risk factor or progression of disease, as well as being unrelated, and that some of these visits might have undergone a diagnostic process, an appropriate diagnostic process at the initial visit where PE was deemed to be low risk. I'm really excited about this work. I'm looking forward to seeing it in Annals of Emergency Medicine. It's in Revise and Resubmit, and if we can do a good job on some of the reanalyses, we'll have it published. Here's the bottom line. Fewer than 1 in 10,000 discharge visits result in a return with a new diagnosis of PE. Among PE cases diagnosed in MEDIC, about 1 in 20 were seen within the ED in the preceding 10 days with a true discharge visit. And some of the most common conditions for return with a new diagnosis of PE, and I think this will be intuitive to many of the clinicians on the call, are COVID-19, pneumonia, and pleural effusion. And so, understanding that although this is not a great tool for what we think of as diagnostic error, it does give us some hint that the people that we discharge, what is the risk that they will later be diagnosed with a PE, that it's sort of clustered in some of these conditions, but especially COVID-19. I'm hopeful that we can develop alternative balancing measure specifications based on chief complaints and discharge diagnoses that can help shine a bright light on the thing that we are all worried about, which would be a true diagnostic error with harm. And whether or not there might be opportunities to abstract that data or help folks look around in it. And that's everything I have for you.
Thanks, Alex. And, certainly follow up with any questions. It's a hot topic, I think, in the emergency medicine sphere around diagnostic error or misdiagnosis because of that ARC report. And so I think it's nice to be able to lend some evidence to that. We do have like maybe 10 minutes left until the end of the meeting time. So it's a little less time for Chris, but Chris, why don't you walk through some of the reporting?
Yeah. Hi, everybody. I'm Chris. I'm one of the faculty at U of M, one of the ER doctors here. What I'd like to do is just sort of walk through some of the reporting that we've built up over the last couple of years to help each individual site explore their own data and to see how it compares to the rest of the other sites in the collaborative. And so we've actually clustered sort of most of the reporting that I've built into this little tab here that's orange that says QI reports. They're a little bit different than the rest of the dashboards because they really are built around some data exploration and for you to sort of play with your own data and to see where you might be able to gain or make some gains in terms of the various metrics. So if you, again, you don't have to follow along right now. Like we're going to make some videos, just some how-to videos, just to make it a little bit easier for people to sort of like watch the video, do a thing, watch the video again, and do a thing. But I'm just going to sort of walk through some of this pretty quickly. So from that landing page, you're going to click on that QI reports. There's not another landing page, and you're going to see actually 4 different reports. You're not going to see these demo ones. I'm going to use the demo ones for our recording here today and for future how-to videos, but you're not going to see those demo ones. The first thing I'm going to do is I'm going to click on all measures, and this is sort of our sort of main homepage one where you can sort of follow all the different modules, not just PE, all the PEDS ones, all the other metrics that we follow at MEDIC. The first page is going to look like this. This is your sort of broad summary page. Each of the different panels has some different information that's sort of very clean, sort of simple displays of like how your site or sites, plural, obviously some clinical champions and some admins can see multiple sites. You can see how you perform relative to the rest of the rest of MEDIC over time, and then against other sort of data points like the number of cases you have. And so that's a good starting point. And then there's this sort of site rankings page. I realize it looks a little weird because this demo data doesn't have very many sites, but when you log in yourself, you'll see, the other 20 to 40 sites, depending on what years and what module you're clicking. And this is not on PE right now. The thing I do want to show you is all the way at the end, we have a new tab for balancing measures. And what I am going to do is I'm going to put this on PE. And so like all the other tabs, there's some filters at the top for you to select your site and to show and hide things. Each of the pages is sort of designed for you to be able to print out as a PDF, because people still do that, or actually print it on paper and give it to your providers so they can see their either their own performance, if it's something that's if it's a view that's centered on individual physicians, or they can see sort of how their group or their site performs against the rest of the MEDIC sites. So I'm going to put this on PE, and for PE there's actually only one balancing measure, so it's going to be pre-selected for you. But if there's multiple balancing measures up here, you're just going to click on the button for it. But for PE it's already clicked. And then as you scroll down, there are going to be multiple panels. The first panel is sort of a performance over time, and basically on one axis you have the actual performance on the balancing measure, in this case, or on the metric measure. So in this case, it's the CT positivity rate for PE. And then on the other axis, you'll have sort of the balancing measure. And in this case, it's an all-cause visit within 7 days prior to that positive CT, and the balancing measures the thick lines, and the metric measures the thin lines, and then obviously the colors are your site versus other sites. This is a scatter plot of the same thing, of sort of the balancing measure versus the metric measure, and then this is actually the case list for the balancing measure. For the ones that triggered the balancing measure or did not trigger the balancing measure, you can sort of sort by which one you want to look at. These are obviously fake names and MRNs. And so that's the new thing on the all measures dashboard. What I'm going to do now is I'm going to go back to the QI reports just to show our new PE dashboard, which you're going to click on when you play with this yourself. It's Clinical Champions PE dashboard. But for me, I'm going to click on this demo one because it has sort of the fake data in it. And then you're going to start off with D-dimer utilization. That's sort of the landing page for this particular dashboard. You're going to give it a second to load, and then it will have sort of this big sort of multi-paneled view to start off with. The look is the same as the other dashboards. There's some information here in the pop-up about sort of what you're seeing. And all the different elements have a little bit of a pop-up information that tells you a little bit of extra information. You can set your dates up here. If you have more than one site, you can select your sites up here. You can sort of check box to include ones you want to include. Right now, the only site that's selected is this sort of medic demo site and then some other fake data. And then what you can do is you can sort of start to deep dive your own D-dimer utilization data for this population of patients that got a CT for PE. This first panel sort of shows your D-dimer obtained or your D-dimer utilization rates for your sites compared to the aggregate of all other sites in Medic for the time frame up here. This next box or this next panel shows this is called a dumbbell plot. In the orange, it shows the selected sites. And then the blue, it shows the aggregate of all of their sites, and then the rate of D-dimer obtained or D-dimer utilization for the different categories of patients. And so we should probably harmonize the nomenclature here a little bit, but I used elevated risk versus not elevated risk. That's sort of the inverse of low risk versus low risk versus not low risk. But it should make sense. And then there's sort of the individual components that make up the elevated risk or not elevated risk, the heart rate criteria, the age criteria, and then the SpO2 criteria. This other panel on the side has some information about sort of the ranking of your site or sites for D-dimer utilization compared to the other sites within Medic. All of those are broken out as a percentage. And so you'll be able to see every other site and sort of what they use, what their D-dimer utilization rate is. Again, you'll see a lot more sites than what I'm seeing here in this demo data. All de-identified, of course. And then for your selected sites, you'll be able to see sort of your cases where the D-dimer was utilized or not utilized by month, or actually you can sort of, depending on the way you have the date set up here, you can sort of, you can make it more granular or less granular. You can sort of change it to quarters. You can change it to whatever display years if you wanted to, or whatever you want to sort of either create a slide or just to look for information for your groups to bring back to your group. And so here's where it sort of gets a little bit more interesting. Is there's two boxes here that present the number of cases where you had a negative CT, so not positive for a PE, where a D-dimer was not obtained. And so what that is sort of getting at is that for the selected sites, compared to the other sites again, is the number of cases where if you had obtained a D-dimer, you might have been able to save the CT and not obtain the CT. And that'll be different for all the different sites, depending on what you click up here and what sites you want to include. And then the next box below that is the number of cases where the dimer flipped from positive to negative after an age adjustment. And so not a lot of cases for the Medic demo site, but it'll be different for your own site. And that's for sites that have reported to us sort of their D-dimer assay, and we've been able to sort of incorporate the D-dimer assay and the sort of the limits of positive and negative with age adjustment into our data. And so for some sites in the past, that's missing. And so and if you change dimer assays, over the years, they may be missing. And so we're working on making that data a little bit more complete over time. And then finally, this last box is for the CT PE positive rate, just to sort of provide that information for the selected sites and other sites. What you can do, which is a little neat, is you can also filter all these other panels by the different risk factors. And so the way to do that is by clicking on these shaded boxes. And so if you are interested in the not elevated risk patients, you just click on it and it will filter every other panel. And so what you'll see in all the other panels and these other sort of dumbbell plots is you're only going to see the cases that are not elevated risk when you click this button. You can unclick that button And you could say maybe just look at patients over 50 or under 50 and sort of deep dive that information there. And the idea behind that is that you can sort of, every site is, we know every site's different in the way their workflows work and the way their sort of algorithm works for, you know, how someone gets to a CT for PE. And so they can sort of take some of this information and try to identify sort of lower hanging fruit in terms of reducing either increasing the D-dimer utilization or even reducing the PECT rates, depending on what your sort of individual local initiative is. And the last thing I want to do is just highlight some of the other tabs, which I'm not going to go over in detail, but you may find useful because these are very good sort of data exploration tabs. Is that there's one tab that will allow you to see sort of your D-dimer, it will allow you to see one metric split up by another metric over time. And so right now what you're seeing is sort of the rate of CT positivity over time for patients who have a D-dimer positive or negative. Obviously, these D-dimer negative patients, it's a little weird because a lot of them, they're actually not included if they don't get a CT scan, but we can change this to sort of D-dimer obtained rate, and that gives you a little bit more information of sort of like what the difference in CT positivity rate is for your selected filters. I won't go over these in detail, but like you're certainly welcome to reach out for questions and that sort of thing. This next page is a scatter plot of sort of whatever you select on the x-axis versus the y-axis, and then sort of it plots that out by site, by your selected sites onto two-dimensional space, and you can sort of see if there's any sort of trends either in the group of sites that you have or across the collaborative, and you know, if you have thoughts about how the entire collaborative may improve, that's certainly welcome as well. And this last thing is called a Sankey plot. It tells you sort of how different populations of patients, of cases proceeds from one step to another. And so you can sort of look how patients go from D-dimer positive to PE positive for your own sites. This one is filtered down to only the sites that you have whose data you have access to, and so you'll be able to sort of get some good information about, like, you know, out of D-dimer obtained patients, you know, how many are positive, how many D-dimers are positive, negative, and then what the CT-PE rate is after that. And so it's a cool little plot to explore. And so with that, I'll stop here just because it is noon. And want to get everyone off to lunch. But if anyone has any questions, I can sort of hang on the call for a little bit for questions, and then you guys will get a YouTube video in your mailbox at some point to sort of explain these a little bit more.
Yeah, thanks, Chris, for walking through all that. There's a question in the chat. I don't know if you can respond to about MRNs. But let me wrap up here. Just a couple final remarks. You know, really appreciate your time and attention as always. I really do hope that what we're able to provide is a lens onto taking some steps towards improvement. I certainly get that, you know, there's a lot of concern out there. It's an imperfect quality measure. I get that, but I do think it's measuring something that is true and something that's important. And I do think there are ways to get better here, and we hope that we provide some spotlighting away around sort of how to do that. Couple of things about sort of upcoming remarks, upcoming events, I should say. Reminder, you know, all these materials, you know, from the collaborative meeting today will eventually make it to our website, and you can review our meeting again. And then finally, a reminder that our next collaborative meeting is going to be hosted in Grand Rapids, beginning of June, and this is going to be a focus on pediatric readiness. We're going to have a guest speaker, Sam Mishra, who is an emergency physician and is in charge of pediatric readiness in our state. So I think that's going to be great to dig into. Thanks so much. Wonderful to see all of you, and we'll close right here. Thanks.